In this lecture, we will be discussing the posterior cruciate ligament. The objectives of this lecture are for you to be able to describe what the PCL is, to describe the clinical presentation of PCL injuries. We also want you to be able to determine potential concomitant injuries that can occur with PCL injuries, and then to be able to describe intervention strategies used to treat PCL injuries. So first off, what is the PCL? It's the largest and strongest intra-articular ligament of the knee, so larger and stronger than the ACL. It attaches to the posterior tibia and runs in a proximal, medial, and anterior direction, attaching to the medial femoral condyle. It is most active in flexion, and it resists tibial posterior translation, femoral anterior translation, and excessive axial rotation, varus, and valgus forces. The primary restraint to posterior tibial translation is the PCL. It's made up of two different bundles, the larger anterior medial bundle and the smaller posterior medial bundle. Studies do suggest that both bundles resist posterior tibial translation at all flexion angles. And it's kind of interesting when you go through knee flexion, usually most people are able to go through quite a bit of range of motion. You don't necessarily feel that tension or resistance from the PCL, and that's because it doesn't increase necessarily throughout flexion. Instead, it's just this constant ongoing tension that prevents from any excessive translation of the tibia or femur. There are both contact and non-contact injuries when it comes to PCL injuries. The highest percentage that is attributed to PCL injuries is a motor vehicle accident, specifically a dashboard injury, where if you're riding in the passenger seat and you have your tibias up on the dashboard, get into an accident, that femur will obviously translate anteriorly, but the dashboard is preventing the tibia from going anteriorly. So that's considered a dashboard injury, and you'll suffer a PCL tear there. The second most common mechanism of injury would be falling on a flexed knee with the foot in plantar flexion. So you're jumping and landing in that position, and there's a higher incidence of PCL injuries with that specific mechanism. PCLs are rarely injured during sport. Soccer has the highest prevalence of that, and then you can see rugby in the bottom right corner. That's a nice PCL injury there, but it only accounts for 0.65 to 3% of total sports-related knee injuries. Only 2.4% of knee injuries in U.S. high school athletes are PCL injuries. A lot of the dashboard injury percentages comes from the study in 1995, so there hasn't been too many updated studies looking at the motor vehicle accident side of things when it comes to the PCL, but according to the evidence we do have available to us, it does seem like it's still the highest prevalence. The PCL injury classification system is slightly different than the LCL and MCL grading system. I'm not overly concerned that you know all of the differences. Instead, I just want you to understand what the main difference is and still apply the rest of the principles across each ligament. For example, grade 1 would be a small partial tear with very minimal impairments. Grade 2 would be a partial tear with some hypersensitivity and maybe some effusion or whatever that might be. And then grade 3 is that complete rupture. As long as you understand that, I think that'll help you grade these ligament injuries successfully, and you'll have success in most exams if you only remember those portions. However, I also want you to know that the main difference between this grading system and the other ones is that here it looks at the posterior tibial translation. Obviously, you're not going to look at that with LCL and MCL because it doesn't have anything to do with anterior-posterior translation, but with the PCL it does. So grade 1 would be 0 to 5 millimeters of increased posterior tibial translation. Another way that they measure that is if the tibia remains anterior to the femoral condyles. Grade 2 would be 6 to 10 millimeters of increased tibial translation in the posterior direction, and another way they measure that is if the tibia is flush with the femoral condyles. And then grade 3 would be greater than 10 millimeters or greater than 1 centimeter of posterior tibial translation, and that's if the tibia lacks a firm endpoint when you're going through the posterior drawer test. The prognosis of PCL injuries really depends on whether it's an isolated injury or if it's an injury with multiple structures involved. And unfortunately, 95% of the time when the PCL is injured, it's accompanied with damage to other structures of the knee. If multiple ligaments are involved, then surgery is typically required. If the PCL is injured in isolation, then typically the patient's going to go through non-operative management. And the reasons for that is because the PCL has good healing potential without any intervention surgically, and we've seen that patients who go through non-operative management have a high level as far as returning back to prior level of function. Patients are more prone to medial compartment OA after the injury, so that's always something we need to keep in mind and continue to learn about, is how do we prevent this more rapid onset of osteoarthritis or symptomatic osteoarthritis after an injury like this. First question, does the patient belong in physical therapy or not? And if they do belong in physical therapy, are they appropriate for a referral as well, or is PT the only thing they're needing right now? There's quite a few different hypotheses that we can develop if we're suspecting a PCL strain, and that could involve different ligament strains such as the ACL, LCL, or MCL. Meniscus involvement, patellofemoral pain, Pez-Ansarine strain. Remember the three muscles, a part of that would be sartorius, gracilis, and semitendinosus. Hamstring strain, fracture, posterior lateral corner injury. There's a lot of different potential diagnoses that can exist here, so it's important that we don't rule them out before we start to investigate more thoroughly with a subjective exam. The clinical presentation of PCL injuries differs depending on whether it's an isolated PCL injury or a PCL injury with other structures involved. If it is an isolated PCL injury, we're going to be looking for that distinct mechanism of injury where there's that posterior tibial translation from a traumatic event. That could be that dashboard injury or landing on the tibia. Any sort of recreation of that posterior tibial translation should lead us towards a PCL injury. The most common complaint patients will have is localized posterior knee pain, especially with any kneeling or squatting. Specifically, the deep knee flexion is what's going to drive their symptoms up. You may also see anterior abrasions, and that goes along with the mechanism of injury. Inability to bear weight is relatively common, but oftentimes the patients will also describe this feeling of instability in their knee. If it's an acute injury and they have a lot of effusion or swelling, you'll also notice that they'll probably have decreased knee range of motion. We'll go through an observation process again. If we're suspecting a PCL injury, we'll do it in standing, assessing gait pattern, do it in long sitting and hook lying. We're going to be assessing the knee in a lot of different positions. But the things we'll look for here are effusion or swelling, abrasions, and posture. You can see here the left knee obviously has some more effusion there, and you can also see, just based on this position, that posterior tibial translation in comparison to the right knee. Clinicians should use outcome measures to assess patients' progress, and the outcome measures that we should be using with our patients if we're suspecting a PCL injury are the IKDC 2000 or the KOOS scale. In addition to that, we should also be assessing psychological status, and we can use the OSPRO 7, FAB-Q, PCS, various other ones depending on which one you think would be most appropriate for your patient. And that can differ quite significantly with a PCL injury. It's not primarily an athletic population we're looking at anymore. It's more of a general population because of that distinct mechanism of injury. So depending on the patient that's coming into your clinic, you'll be able to differentiate between which psychological status outcome measure you'd want to provide. Here's a list of various physical impairments you may expect to see with PCL injuries. Joint range of motion will typically be more affected into end range flexion. That deep knee flexion often reproduces symptoms, especially if there is a lot of effusion. So effusion is another thing we should be assessing during our exam. Knee laxity and instability may be one of the impairments that we find with our patients, especially if they've sustained a grade 3 tear. Movement coordination is something we can assess by going through some functional testing or balance testing, seeing how comfortable they are with being on that leg. If they do have a higher grade injury, then there's probably less likelihood of them feeling confident on that lower extremity. Strength of the quads and hamstrings will be important to assess, and oftentimes the hamstring strength will be more limited if it's a PCL injury. And then pain with palpation of the posterior knee is a very common patient complaint. Even though there might be a clear mechanism of injury and a distinct area where the patient might have symptoms, it's still important to go through thorough palpation of the knee itself. First of all, you want to palpate the patella and the fibular head to see if there are any signs or symptoms that would indicate the need for an immediate referral for radiographs. Other than that, we would want to also palpate the tibial plateau. You think about it, if it's a dashboard injury or a significant mechanism of injury where you're falling onto that superior tibia, there may be risk for a tibial plateau fracture, and we want to be able to assess for that. Joint line tenderness may be associated with a meniscus tear, so we want to be thorough in our palpation with the joint line as well. If we palpate both medially and laterally, we may be able to pick up on some possible concomitant injuries to the MCL or LCL. And then lastly, the posterior lateral corner with the rotary forces that may be involved with this type of injury as well. Here's a list of a handful of special tests that you may consider performing on your patients if you're suspecting a PCL injury. The quadriceps active test, the posterior drawer, posterior sag sign, reverse Lockman, reverse pivot shift test, and then the composite exam where you add up all the different data at the bottom there. The ones that I'll do most commonly would be the posterior sag sign, that's just more of an observation, and then the posterior drawer assessment. If I'm still not sure at the end of my examination if it's a PCL injury or not, then I may consider doing the quadriceps active test or one of the other reverse Lockman, reverse pivot shift test. The posterior sag test is performed with the patient in supine and the hip and the knee flexed to 90-90. Clinician supports at the ankle or the heel, and a positive test would be sagging of the tibia. A quick and dirty way of doing this would just be having the patient in hook lying and seeing if there's any posterior translation of the tibia in that position. But to do the test as accurate as possible, you'd have them in this position. When I do this test, I usually just have them in hook lying, and that's the first test that I'll do during my algorithm. The posterior drawer test is the other common PCL test that I'll do, and it's performed with the patient in supine, the knee flexed to 90 degrees with the foot on the table. Clinician will sit on the foot, and you're going to provide that posterior translation to the proximal tibia. Positive test would be increased posterior tibial translation compared to the contralateral limb. The quadriceps active test, or the active drawer test is another name, is performed by having the patient in this supine or hook lying position with their knee flexed to 90 degrees and with you providing support at their ankle. You're going to ask the patient to contract their quads, and if you see excessive anterior translation of the tibia with that, that would be considered a positive test. Another element to this test that you can add is asking the patient to contract their hamstrings. If that increases the posterior sag of the proximal tibia, that would also be considered a positive test. Reverse Lockman's test is going to be the opposite of Lockman test. You have the patient in supine with the knee flexed to 20 to 30 degrees. Typically, I'll put my knee under their distal thigh, or you can put a bolster under their distal thigh to stabilize there. And you're going to stabilize the distal femur with the proximal hand and apply a anterior to posterior force with your distal hand at the proximal tibia. If you notice increased posterior tibial translation, or if you notice an absent endpoint, that would be considered a positive test. The reverse pivot shift test is the one that I'm least likely to perform in the clinic. I find that patients are just more likely to be apprehensive with this. This test can also be used for the posterior lateral corner. In order to conduct this test, you're going to have the patient in supine with the knee flexed to 70 to 80 degrees. And then as the clinician, you're going to support the limb, the proximal hand at the knee and the distal hand at the distal tib fib region. With your distal hand, you're going to externally rotate the limb. And the book will say that the weight of the leg will allow the knee to extend, but what I find is there's too many variables and you're going to have to provide this extension force to extend the knee. However, how the book describes it is the weight of the limb will allow it to straighten. You're going to apply this axial load with the distal hand. Sometimes you're going to have to use your body to provide that axial load. At the same time, you're going to apply a valgus force with your proximal hand. As the knee goes through extension at about 20 degrees, you'll notice that the tibial plateau will jerk anteriorly. From a posterior and externally rotated sublux position, it's being reduced and returning back into a neutral position. That would be considered a positive test if you see that anterior tibial jerk. PCL injury management can be either non-surgical or surgical. The main factors that go into that decision are whether it's acute or chronic. If it's a chronic injury where it's been going on for a long time, it's more likely to be treated non-surgically. And then the other factor would be, is it an isolated PCL injury or a combined PCL injury? If there's multiple different ligaments that are injured or structures that are injured, then surgery is more likely to be conducted. If it's an isolated PCL injury, then non-surgical management would be preferred. Non-operative management focuses on using tissue healing principles and irritability to guide the rate of progression for your patients. There is poor evidence for bracing following a PCL injury. However, if you have a bunch of concomitant injuries, you have high levels of instability, or if the patient is extremely apprehensive, you may consider using a brace at that point. But according to the research we have available to us, there's no added benefit to bracing for a PCL injury. I would encourage you to use performance measures that you've already been taught for other lower extremity pathologies. And the reason for that is because there's no specific evidence for PCL items, or no performance measures that are specific to the PCL is maybe a better way of saying it. The average time for return to sports is 16.4 weeks if it's an isolated PCL injury. And the other number that was kind of interesting is 2 years after the injury, 91% of athletes were playing at the same level or a higher level than they were prior to the injury. So good outcomes overall. Here's a 4-phase program that you can consider implementing into the clinic if you have a patient with a PCL injury. It does a good job for the most part of following the tissue healing principles, so you can feel pretty confident if you use this in the clinic. The first phase is the protective phase, weeks 1 to 6, where you're going to be focusing on increasing mobility, managing symptoms, and increasing quad activation. I would add to that and also say let's focus on hamstring activation, as with PCL injuries you're going to notice a higher level of hamstring weakness as well. Transitional phase is weeks 6 to 12. This is where we're going to be focusing on enhancing proprioception and strengthening the lower extremities. The functional phase is weeks 12 to 16. Going to be implementing more closed chain exercises, proprioception, and neuromuscular control exercises. You're also going to be introducing some more activity-specific interventions at this point as well. And then the return to play phase would be weeks 16 to 24. Remember in the previous slide, the one study highlighted that the average return to play time frame was 16.4 weeks. So if you have your patients get back that quickly, you should be doing this return to play phase a little earlier on in their rehab. PCL surgery is performed arthroscopically now. However, if there's multiple structures involved, that may increase the likelihood of them having to do an open procedure. If it's an isolated PCL injury, it's going to be done arthroscopically. The best technique is still debated. Research is relatively conflicting in these areas. Should the surgeon do a single bundle or a double bundle? Should they do a transtibial tunnel or a tibial inlay? I'm not an expert in surgical techniques, it's just what the research is showing. So the thing I do know is outcomes for PCL surgical management have been improving, and I think part of that is because the surgical procedures themselves have been improving. An arthroscopic procedure is better than an open procedure. Some of these different techniques can be more beneficial for our patients versus others. So surgical management is improving. Still, if it's an isolated PCL injury, may not be the most appropriate management strategy. Postoperative management can be broken into 5 different phases. The first phase, the patient will be non-weight bearing. And the reason for the patient going through 6 weeks of non-weight bearing is because the PCL has been shown to heal twice as slow as the ACL after a reconstruction. And remember, the ACL kind of depended on the graft that was used. If it's an bone patellar tendon bone graft, it can begin to go through that vascularization at the 6-week mark, versus a hamstring graft is 12 weeks. So if we're looking at double that, we're looking at a minimum of 12 weeks for the PCL. And that's why they're more conservative with the weight bearing early on with PCL reconstruction. So phase 1 is going to be non-weight bearing. You're going to do progressive range of motion. However, with progressive range of motion, you're going to prevent any hyperextension and posterior tibial translation. The second thing here is going to be the patient will be using an immobilizer for the first 2 weeks, followed by a dynamic knee brace. Phase 2 will be weeks 7 to 12, where the patient will continue using the knee brace. Here, the patient will be partial weight bearing or weight bearing is tolerated, and that's when you can initiate some of these closed chain exercises. With the closed chain exercises, you're only going to have them go up to about 70 degrees of knee flexion, and you're going to initiate some open chain strengthening here as well. Postoperative management, phase 3 is considered weeks 13 to 18. Here you're going to continue with that dynamic knee brace in addition to progressing range of motion and strength. The 70 degree of knee flexion rule is still going to apply until week 16. At week 16 for closed chain exercises, you can go beyond that 70 degrees of knee flexion. Phase 4 is weeks 19 to 24. This is when you can ditch the brace and begin introducing some sport-specific drills, in addition to progressing strengthening and maintaining the full range of motion. Now, it might seem like a big jump from week 16, not even doing more than 70 degrees of knee flexion during closed chain exercises, to all of a sudden doing sport-specific drills at week 19. However, it's important that you remember all of this falls on a continuum. We're not going to be making these big jumps, but instead you're going to slowly introduce these new activities throughout this 5-week period. Phase 5 is the return to sport phase, so we should be focusing on high-level strengthening, functional activities, sport-specific drills, and preparing them for their return to sport testing, making sure that they're able to do all their functional tests such as hop tests, similarly to the contralateral limb, making sure that they demonstrate enough psychological readiness, making sure their isokinetic testing is within normal limits when comparing to the contralateral limb, and any additional tests that you would like to include in your battery when it comes to returning to sport. We've covered a lot of different items over the last few lectures, so I think this would be a good point in time for you to take a moment and ask yourself a few of these questions and see if you're able to do it without looking at your notes. So the first would be describe common mechanisms of injury for MCL, LCL, and PCL injuries. Second question would be, or second challenge would be to see if you're able to describe the grade of ligament injuries and how that may affect PT interventions. And then lastly is differentiate the clinical presentation for a patient with an isolated MCL injury versus PCL injury versus LCL injury. If you have any questions, please let me know.